A key part of what we think our job is to put people on an upward life trajectory. This isn't just about like getting them, matched to a benefit. This is about re-empowering them to take control of their lives. And so we have so many stories of people who we met like living in their car, get them enrolled in our program, get them somewhere to stay, like to live on a short-term basis and stabilize themselves, get them into a job training program where then they go on to get a job and end up in a market rate apartment that they're paying for themselves. And so we see that as our role is to get people back on an upward life trajectory.
Hey, this is Jonathan Marx with GoToHealth. How are you today? I hope you're having a great day. This is a wonderful show about new coverage for Medicaid patients. And I'm talking with the Chief Medical Officer from PAIR Team. It's PAIR. They are a tech-enabled medical group reimagining how Medicaid supports the most underserved populations. They're serving people in California. They're reaching out to people now in Nevada and soon Texas. It's really an incredible organization. They're serving high-risk Medicaid members with a mission to improve access in communities and populations that face persistent barriers to care. PAIR Team partners with trusted local organizations to build community care hubs, which are networks rooted in the community that connects individuals to medical, behavioral, and social support services. You may ask how they're funded, but let me tell you, they've had a 52% reduction in emergency department visits. They've had a 26% reduction in inpatient admissions. They've had a 21% increase in outpatient care and a 20% cost savings among high-cost Medicaid beneficiaries. So Medicaid is actually happy to pay PAIR Team to keep people out of the hospital and keep them on much lower cost kinds of care. We're talking today with Nate Favini, MD. He's the Chief Medical Officer at PAIR Team, which is at pairteam.com, and that's PAIR. He's responsible for overseeing the standards of care across the many communities that PAIR Team works in, and also making sure that the numbers are improved in terms of health outcomes. Before we get to Nate, just a reminder, if you're liking our programming, if you could please leave us a 5-star review on Apple or Spotify or a thumbs up on YouTube. It greatly helps us get the word out. Thanks in advance. So welcome to the show, Nate Favini. How are you today?
I'm great, Jonathan. Thanks for having me.
Good. So tell me, what is it that has made PAIR Team successful? What's your model that you're bringing around the country?
Yeah, we have a really novel model for the care of high needs Medicaid beneficiaries, and we're both a technology platform, a medical group, and an integrated network of community-based organizations that provide wraparound care to the highest need folks in Medicaid. So think of people, people who are experiencing homelessness, severe mental illness, substance use disorder, kids in the child welfare system, people returning from incarceration, seniors at risk of institutionalization, the people who kind of have the most complex cases from a medical, social, and behavioral health point of view. Those are the people that we work with. And we have a team, a really robust team that includes community health workers, nurses, behavioral health care managers who are LCSWs, and nurse practitioners who really provide a wraparound care model to those patients. The CHWs, the community health workers, are really the most critical part of that because they build the relationship with the patient. They're from the community, they speak the language, and they really help carry that relationship with the patient. The rest of the team provides the wraparound care. And then critically, we have community-based organizations in the community. So think of like shelters, food pantries, the Salvation Army, organizations that provide childcare, that help us meet the social needs of our patients. And we actually pay them for providing those services. So this is not just like we refer you off to get social care and hope or pray that it happens. Like we're actually in contracts with those community-based organizations that provide the social support services. And that's really important for getting folks to engage with us. And I think that's really the key of how we get folks to engage, because we're not going to you and saying, hey, about the fact that you're in the emergency department all the time, or hey, about your uncontrolled diabetes. We're going to you and saying, hey, about the fact that you don't have a place to sleep tonight. We can help with that because of our partners. That's how we get you engaged. That's how we start making progress. And then we can start to intervene on your health needs as well and really get you on a different trajectory than you've been on.
Fabulous. I've kind of perused your website. Do I understand that your services are free to clients?
That's right. They're all paid for by Medicaid.
Okay. So, and how are you folks supported? How do you support yourselves?
Through revenue from Medicaid, we have contracts with Medicaid managed care plans. And so they pay us for these services, and it's worth it to them from a return on investment perspective because we can help keep folks out of the emergency department, out of the hospital. We just published a study in the Journal of General Internal Medicine, and we have a 52% reduction in ED utilization and a 26% reduction in hospital admissions. And so paying for our care management services is much cheaper than paying for those acute care episodes. And so it's worth it from the health plan perspective to pay for this because it keeps people out of the hospital.
Got it. Amazing. What states does Pear Team operate in currently?
We are currently in California and Nevada. We just launched Nevada this year. We've been in California for a few years, and we are planning to launch Texas early next year.
Wonderful. And Nevada is really a pretty big population for you. I mean, so I understand there are quite a number of people who are benefit from Medicaid in the Las Vegas area. Is that true?
That's right. Yeah, Nevada is a really interesting state because you've obviously got the metropolitan area around Vegas, you've got Reno, and then you've got this like vast rural area in the
Yes.
state. And I think the reason why our plan partners have been interested in bringing us into Nevada is we're really good in both those urban and rural environments because we don't depend on traditional health system infrastructure. We're depending on community-based organization infrastructure. So in the rural areas, that might be churches, for instance, or other faith-based
Mm.
organizations.
Hmm.
And it's faith-based organizations in the cities too, but then it's also like the nonprofit infrastructure in those areas. And so yeah, we've made Clark County our first place to focus in Vegas because that's where the most people are and the most need
Right.
is. But we're excited about serving all of Nevada because we think our model works across both urban and rural geographies really well.
Let's talk about, if you don't mind, and you know this, but I like to repeat this, the difficulty of getting healthcare in rural areas. Can you describe that for us, what that's like for people who live in rural areas?
Sure. I grew up in a rural part of the country
Okay.
and have seen a bunch of these challenges firsthand, whether it's myself, my family, friends. And there is often just not the healthcare infrastructure in those places that you have in other parts of the country. My dad's actually an emergency physician in a rural part of the country. And
Hmm.
so I grew up on all these stories from my dad of people he was taking care of in the emergency room who were much sicker than they should have been because they didn't have good access to primary care, preventive care. They had health-related social needs that no one could really help address. And so when you don't have the infrastructure, right, like when the closest primary care provider is over an hour drive away, you tend to not get those services. And then it becomes even more true if you need specialty care services, right? You might be talking about like a 3 or 4 hour drive to see someone who is specialized in the thing you're dealing with.
Right.
A lot of these things just end up being not addressed in a timely fashion or swept under the rug until they become something much more acute.
Got it.
Yeah.
And if you don't mind, if we can talk about the big cutbacks to Medicaid in the coming big beautiful bill, and
Yeah.
that's going to particularly affect rural hospitals where they may have to close and go out of business. Can you talk about how this big beautiful bill is going to affect Medicaid coverage and how it's going to affect your organization? Will you still be able to function?
Yep. Yeah, there are a few big provisions in the Big Beautiful Bill, HR 1, that impact Medicaid. I think a couple of the biggest are the reduction in provider taxes. A lot of states fund their Medicaid programs by taxing providers or health plans within their state, which then allows them to draw down more federal matching funds.
Hmm.
the bill really limits the law, really limits the amount to which states can do that. And so you're just going to see less funding in the Medicaid system in general.
Hmm.
And then, of course, you've got the community engagement requirements, right? That people be either working, volunteering, or in school or training for at least 80 hours a month to qualify for Medicaid, with a bunch of exemptions for pregnancy and people with dependents and those types of things.
Right.
But that is really going to lead to two things: fewer dollars in the Medicaid system, and fewer beneficiaries in the Medicaid system, because people are going to lose their Medicaid coverage if we don't engage them and keep them enrolled. And so it's really creating two big pushes industry wide. Number one is, I think everyone recognizes we're going to have to be able to do more with less. We need solutions that allow us to use our funding wisely, and identifying high needs patients and being able to reduce their acute care utilization like we do is a great way for Medicaid programs and managed care plans to save dollars that then they can reallocate to other places, right? And then the second is engagement. We really need to engage people and keep them engaged in the system, because they're going to have to demonstrate every 6 months that they're still eligible for Medicaid.
Mm.
And that's not going to work if you can't engage people. And so you need a way to engage folks. And our pretty strong hypothesis that we've validated now across a bunch of markets is that you can engage people way better on their social needs than you can on health needs. It just doesn't speak to people in the same way when you're doing, like I was saying, when you're doing outreach about their diabetes as when you're doing outreach about their childcare, right? Like if you think about how you would prioritize those things, you're going to prioritize the social need first. And so to the degree we can build programs that engage people around those things, we can keep them engaged in our system and therefore keep them enrolled in Medicaid. All these things will prevent loss of funding in the system that can then be used to invest in health services in the community.
So your model emphasizes whole person care,
Yes.
integrating medical, behavioral, social services as you just described. Can you give us an example of what that looks like on the ground for a Medicaid member?
Sure. It's common that we meet folks when they have lost their housing, and that's where things have become acute to the degree that someone recognizes that they really need help. And they might walk into an organization that we partner with. It might be a shelter, it might be another housing nonprofit in the community. And they might walk in there, and our community health worker on the ground might say, "Hey, in addition to helping you here, you're also eligible for this care navigation program. Would you be interested in that?" Or they might go on their phone, or they might go to the library and they might Google help with housing. And if they do that, they're gonna get served a link to the Pear Team website,
Hmm.
and they'll fill out a form if they go there. And we actually get a significant number of our enrollees this way. They fill out the form, and then we call them and say, "Hey, we can help you find a place to sleep tonight. We can get you healthy food." And that's how we get them linked into our program. And then from there, our team engages them and finds out what their needs are. They might be a single mom with two kids, and we need to get them into a family shelter. They might need to be a veteran who needs to get into a veteran shelter. They might be living in their car and they don't want to go to a shelter at all, but we need to get them into affordable housing. And so we'll work with an affordable housing partner around that. A key part of what we think our job is to put people on an upward life trajectory. This isn't just about getting them, matched to a benefit. This is about re-empowering them to take control of their lives. And so we have so many stories of people who we met, living in their car, get them enrolled in our program, get them somewhere to live on a short-term basis and stabilize themselves, get them into a job training program where then they go on to get a job and end up in a market rate apartment that they're paying for themselves. And so we see that as our role, is to get people back on an upward life trajectory.
Amazing. So let me just tell people the website where they can go to learn more. It's pairteam.com, and that's PAIR, pairteam.com. Where does the name come from?
It really comes from the notion of partnering with our patients, pairing with them, the work
Uh,
that our community health workers do, and that we as an organization do, is partnering and pairing with people to accompany them on their life's journey.
and how do people find out about you or get your services? Do most of them come through the website, or did they come through community organizations that hook up with you?
Yeah, those are the two most common. They find us online and fill out a form on our website, or they come through a community-based organization. They might also come to us through one of our hospital partners. We have partnerships with hospitals so we can meet people when they're in the ED
Mm.
or in the hospital. And in some of those settings, we actually have our community health workers in the hospital so they can go around and meet someone right there while they're in the emergency department. They might meet us through one of our partnerships with an organization for people who are involved in the criminal justice system. So, like when they're being released at the end of their sentence, we
Hmm.
partner with organizations that try to support those people and get them back on their feet in the community and prevent them from ending up incarcerated again. And I think those are probably like the most common ways. Oh, they might also meet a like if they happen to this is not the most common case because 85% of our folks haven't seen a doctor in over 3 years.
Wow.
But if they are going to a community clinic or something like that, we also have partnerships with community clinics so that when they identify people who are eligible for this program, they can refer people to us as well.
So you just mentioned quite a number of community organizations that you associate with, and
Yeah.
coming new into Nevada, that must be an incredible resource of coming in with staff and spreading out and letting everybody know that you exist and can provide these services. Sounds like a massive effort on your part.
It is. We have an entire team of people that are dedicated just to building out our network in the community, and it takes a ton of work to get there. We can start with just a few partners. Like we don't have to be in every organization in the community to start, but the longer we're in a community, the deeper our integration goes, and the more you start to see network effects from that, where like people across the whole health and social care system know about Pair and can get people connected to us. And that's really the vision is like, can we turn what is today essentially like a bunch of isolated organizations all working on
Right.
their own goals? Can we really bring those things together to form a true safety net for people by bringing them all together on the Pair Team platform?
So as you fan out, you're working with a tremendous number of healthcare professionals. You are the chief medical officer. What's your job as the chief medical officer for Pair Team in, I guess, establishing a standard of care for everybody you're working with? That must also be a huge job.
Yep, that's a big part of what I work on is supervising our clinical teams, making sure that the care we provide to people is really good and the type of care that we would want our family members to receive. And then as part of that, making sure that we deliver the clinical outcomes that we care about and that our health plan partners care about. Because ultimately it's the fact that we're able to keep people out of the hospital that pays for this program. And so
Mhm.
we need to make sure that we're delivering on that for our patients and for our health plan partners because it doesn't work if we can't make this work financially. And so that's a big part of my job too is paying attention to the utilization measures, the quality measures that we deliver. The health plans care a lot. They don't just care about utilization. They also tend to care about HEDIS measures, which are healthcare quality measures. So they care a ton that like we're improving the diabetes control, the blood pressure control, which we do, that we're improving depression rates, and we do. We have a 57% depression remission rate, which is
Amazing.
pretty compelling. And then they care a bunch that we get transitions of care done, meaning when someone leaves the hospital, are we in touch with them within 7 days? And so those are the types of things that I really focus on from a healthcare quality point of view.
And how do you keep in touch with people throughout this whole process? Does everybody have cell phones or computers? I would imagine many don't.
Yeah, people are often surprised to find that almost all Medicaid beneficiaries have a phone, at least. It may not be a smartphone, but they have a phone. And so we've specifically built our tooling to rely on voice calls and SMS messages. We don't
Okay.
have a patient-facing app or anything like that because we want to make it so that you can use it on the most basic phone that you might be able to buy. And we're also aware that the folks we work with can like sometimes lose their phone plan, like they can't pay for it in a given month, or they lose their phone and get a new number. And so we have ways to overcome those types of challenges as well. For instance, when we first start enrolling someone and we're building that trust, we'll say, okay, if you lose your phone or your phone gets disconnected, what are some other ways we can reach you? Who else in your family has a phone that we could call and talk to you on? Right. And if you do lose your phone and you're getting a new number, here's how you're going to tell us that you have a new phone and a new number. And so we have plans to make all those things happen. And it works. We have 95% retention of our patients, which again is like pretty remarkable with this patient population. And I think again goes back to the fact that we're engaging people on their social needs. It's the thing they have intent around, right? It's not us forcing this on them. They want to stay in touch with us because they know we're helping them with the stuff that they care about.
That's just amazing. Now, one question I have that I'm starting to do more and more shows on is the application of AI
Hmm.
in medical care. Is are you guys at Pear Team using AI in any way? And tell us what ways you're using that.
Yeah, we are. We're starting to explore this and we want to be really thoughtful about how to use it. I would say that in the communities that we work with, trust is really important. If you lose people's trust, the whole basis for this intervention falls apart.
Yes.
So we need to be really thoughtful and cautious about how we implement it. For that reason, a bunch of our implementations to begin with, have really focused on sort of back-end implementations in our tooling, where we have an entire software platform that our intervention runs off of. It codifies all the workflows that the care team should be doing with patients. And you can imagine those workflows can then become the guardrails in which you can implement an AI agent to do specific tasks, especially administrative tasks that were taking a lot of time from our care team before, and
Right.
and allows us to start automating those tasks with AI agents. We're also starting to explore whether we can try having AI have direct interactions with patients in certain scenarios. Because if you think about our intervention, like the way we pay, it's a very labor intensive intervention, what we do today, right? Like
Yes.
you heard about the entire team that we have. And the way we pay for that is with the savings on acute care utilization reductions. And so that means we can do this with a high risk population with high baseline healthcare utilization. Harder to do this for people who are like low and moderate risk in Medicaid to begin with, but still have social needs and still could absolutely benefit from this kind of support. But imagine if you could do that in an AI led sort of way that allows you to do it at a dramatically lower cost. You could scale this kind of support across the entire Medicaid population and probably even beyond, right? To people in Medicare or ACA plans. And there are people in commercial plans who have real social needs, right? But if you could do this at a much lower price point because AI would enable it, you could get this kind of a service to everyone, which I think would be really valuable to them and to the health system. But we have to be thoughtful about it, and we have to make sure that the tools we're using are safe. We have to evaluate them for bias, particularly in the communities that we're working in, to make sure that they're behaving the way we want them to. But as we do that, I think we want to move into a world where we can make this accessible to more and more people.
You know, the system that you're talking about, it's just amazing the breadth of what you're doing. Does this have application for other patient populations that are not on Medicaid? I mean, it's just such a wonderful way that you have of engaging people and keeping them engaged. And
Yep.
that's so important for keeping people healthy, regardless of if you're on Medicaid or not. Is this expandable to other types of healthcare coverage?
We think so. We're already working with dual eligible beneficiaries, so folks who are in both Medicare and Medicaid. And we know that for those folks, like the savings that we generate on those folks is even bigger than what we generate on Medicaid beneficiaries,
Sure.
like order of $25,000 per patient per year. So it's really meaningful. But then if you look more broadly, there's an entire segment of Medicare beneficiaries who are low income, fixed income, really like probably only don't qualify for Medicaid because of some asset that they have, but they're like actually quite low from a cash flow perspective, and
Hmm.
are making choices between do I get the healthy food that I need, or do I get my medicines, right?
Right.
And that's a population I think that we can help a lot with, and maybe even prevent them from needing Medicaid because you can get them stabilized on their Medicare benefit. And then if you look within like ACA individual market plans, there's a lot of low income folks with social needs. Even if you look in commercial plans, there are a lot of folks who are experiencing real social needs, real
Sure.
behavioral health needs. that I think we could be really helpful with. And so Medicaid is the place we got our start, and we are really committed to continuing to grow in Medicaid because there's a lot of people who need us in Medicaid.
Hmm.
But we are also looking at these other markets as well.
How old is Pear Team? How long have you been doing this?
The company is about almost 7 years old,
Okay.
and actually started doing essentially quality improvement for federally qualified health centers. So, working with community health centers, trying to help them improve the quality of care. And so that's what kind of got us like into the community, close to the ground of what was happening. And then we saw this opportunity to sort of provide this intervention for folks who really needed us.
Gosh, that's great. If people want to learn more, they can go to pairteam.com. That's PAIR, pairteam.com. And pairteam.com seems like it's a place for not only patients, but also for community organizations to connect with you, correct?
That's right. Yes, if you're a community organization in California or Nevada or Texas, we would love it if you went there and reached out to us via the site, and we will have our partnership team reach back out to you so that we can partner together.
Good. So, Nate, we get to this part of the interview where I ask, what question didn't I ask that I should have? Or what big message would you like to leave people with today before we end?
That's a great question. I think the big message I would like to leave people with is, I think there's a lot of anxiety about the headwinds facing all of us who work in Medicaid and the limitations, the new constraints that we are going to have in terms of funding and redetermination requirements and those types of challenges that we're going to be dealing with. But I want to encourage all of us who have really made our careers in this field to look for the opportunities that this period of time is going to force, because I think we can do a lot to make the Medicaid system dramatically more efficient while making the care better, while forcing ourselves to do better at engaging patients in the community in a way that we could come out of this with a much better system of care for people who rely on Medicaid than we had before. But only if only if we really seize the opportunity to do that rather than letting this happen to us.
Nate, it's been wonderful to have you on the show. I'm so thankful for the services and the organization that you're providing to so many people with Medicaid. I'd love to have you back on the show to hear,
Yeah, of
more about your progress and how things are going, if you'd be interested in doing that.
course.
That'd be great. Good. We've been talking with Nate Favini, MD. He's the Chief Medical Officer at Pair Team, and that's PAIR, Pair Team at pairteam.com. They're an innovative Medicaid provider that connects underserved communities to high-quality care by partnering with local clinics, shelters, food pantries, and other community-based organizations. Nate earned his medical degree from Harvard Medical School, and he was also at Montefiore Medical Center in the Bronx and the Robert Wood Foundation at UCLA. Nate, thanks so much for being with us today. It's been an honor to talk with you.
Thanks for having me, Jonathan. This is really fun.
Good. This has been Jonathan Marx with GoToHealth. And if you like what we're doing, please give us a 5-star review on Apple or Spotify or YouTube or wherever you're listening to us. It helps us spread the word and keeps this programming free. Thanks so much for being with us today. This has been Jonathan Marx with GoToHealth. And as we say at the end of every show, go to health. Take care. We'll see you again next time. God bless. Bye-bye. Thank you for tuning in today to Go to Health. You are one of almost 10,000 people per day who enjoy the evidence-based health information offered by our guest health experts. You can watch us on our website and YouTube and listen to us on 8 podcast networks. Be sure to join Jonathan Marx in our upcoming shows each week. If you like our show, please share this episode with your friends and colleagues. You can subscribe to the show, join our email list, send us feedback, browse through the online store, and view our library of over 150 shows at gotohealthmedia.com. See you next time, and remember to elevate your life with Go to Health.